Hello, my name is Kathleen Momsen. My area advanced nursing practice is adult surgical population. My evidence-based educational innovation project is what are the non-pharmacological interventions as an alternative to antiemetic medications provided by the perioperative nurses to treat perioperative nausea and vomiting, also called PONV. Postoperative nausea and vomiting occurs within the first 24 to 48 hours after surgery in at least 30% of all general surgical patients. The number can be as high as 80%. There are multiple factors that cause PONV. Gender, type of surgery, and type of anesthesia are just some of the most common that affect the physiological mechanisms in the human body. Potential complications include wound dehiscence and dehydration that delayed discharge and can result in readmission after surgery. This affects patient satisfaction with the care provided, as well as may affect hospital reimbursement rates. While working in the perioperative area, phase 2, I discovered many patients were still nauseous upon discharge. They received prescriptions to follow up with other antiemetics, but not other means were provided other than their prescriptions. Many patients stated that the medications, due to cost, side effects, negative interactions, the extrapyramidal side effects they've already experienced, and sedation, delayed their use in using antiemetics because it affected their activities of daily living, as well as did delay some patients leaving the surgical area. I also had many patients say they just did not want to take one more drug. What to do and what are the options? So I conducted 2 surveys. Once amongst perioperative nurses, asking what are your non-pharmacological interventions? Do you chart them? Do you teach them to your patients? I followed up, are these evidence-based or traditional? My second survey was conducted with post-op calls from the discharged patient chart reviews. I looked to see if there was non-pharmacological interventions charted by the nurse in the hospital, and was there teaching on the discharge planning. Feedback from these surveys showed that perioperative nurses are knowledgeable on the pharmacological antiemetics, but they did not know many non-pharmacological modalities or even where to chart them. And some nurses stated they don't even recall teaching them to their patients. This led me to focus my innovation on highlighting the need for more education on recognizing high-risk patients, current evidence-based non-pharmacological treatments, and teaching patients about non-pharmacological interventions from pre-op through discharge to home and documenting it in the electronic medical record. From this, I developed an innovation plan of a 1-hour module via lecture with PowerPoint and hands-on skills in a computer lab EMR documentation segment to be taught to nurses that are new to the perioperative area during the PACU fellowship orientation in a classroom setting at our hospital facilities. These nurses are new to hospital work, and some were just new to the perioperative area but had experienced nursing and other modalities. I use cognitive theory for my PowerPoint lecture and computer lab. I divided the module into sections or chunking information that would help build new knowledge upon old information. I'm focusing on one subject at a time to help retain information into memories. The PowerPoint lecture encompassed pathophysiology behind nausea and vomiting pathways, the risk assessment scale screening, current medications and their most common side effects, as a review for nurses. As a change of pace, the class scenarios were interdispersed during the lecture, discussion and use of feedback and critical thinking in a group format where patients are most at risk, what intervention was used, where would you chart these, would motivate interventions and techniques for nurses to teach their patients from pre-op through discharge. After a small break and a review of data covered, the students were introduced to the international guidelines developed and accepted by International Anesthesia Society on PONV. They have extensive research that suggests screening factors, antianemics, and multimodal approach to preventing PONV should be adopted. Current evidence-based non-pharmacological interventions, or the A1, which is the multiple randomized controls supported by meta-analysis literature, were presented from the guidelines. In my PowerPoint lecture, I added videos of aromatherapy, which is an A1 that we currently use in our facility. Another video I use is acupuncture, which is another A1 modality currently used throughout the world, but not so much here in the States. But we do see it amongst our patient population currently, and we'll probably see it more frequently. They were added to the PowerPoint to integrate information into memory. Each video was followed by a hands-on demonstration and return demonstration to improve understanding and recall of techniques. It also provided visual reinforcements and active learning. I also added music as an A1 modality, which is best used in children. After a break, we met at the computer lab, where we engaged learners in documentation of interventions to help support patient teaching and to help increase patient literacy and decision-making about their care. The intended outcome of this innovation is to have perioperative nurses provide non-pharmacological, evidence-based techniques as an alternative to antiemetic medications to treat PONV from pre-op through discharge. The perioperative nurses coordinate patient-centered care treatments and educate their patient to help improve their quality of care. It is followed by an assessment at the completion of class. The nurses will participate with a multiple choice assessment tool or a quiz developed from a curriculum blueprint. A passing grade of 80, answers right assess that the nurse has received basic knowledge of non-pharmacological interventions, risk scale, and charting in the electronic medical record are met. Students may retake the test if an 80 is not received after discussing missed questions with the educators. A final evaluation tool of a QR code survey on the class and the educators to be completed. Using the Likert scale, using strongly agree to strongly disagree regarding topics, outcomes, the educator, and the instructional materials is covered. This data is used to improve the innovation plan, materials, etc. The future plan is to teach these techniques to other departments to help their patient population with nausea, vomiting, pain, and anxiety when pharmacological interventions do not meet the patient's needs and provide patient autonomy with their own care, with the possibility to increase patient satisfaction with the hospital. Thank you for listening.